Well, good morning, everyone. Excuse me, I guess it's afternoon. I'm in Washington. I keep forgetting that. Well, good afternoon and welcome to our first in a series of 3 professional talks for the SOFT virtual conference. We're excited to be bringing this to you. It's something that I know Dr. Carey has talked about for a while, and so we appreciate everyone taking their time on this Monday to join us for our talk today. And just a little bit of housekeeping. What we'll do is Dr. Carey will go through his slides and then just kind of hold questions, write them down if you need to so you don't forget them. Put them in chat if you want to so you don't forget them. But when he gets done, at the end, there'll be you'll be able to raise your hand. We'll go through in order to get questions. When your question is called on, you'll actually be activated. So you can, if you have a microphone, let us know if you don't. But if you have a microphone, you'll be able to ask Dr. Carey the question yourself. We thought that would be the simplest way to handle questions today. And we're going to go just about an hour today. And again, we just appreciate so much our ability to bring this to you. And we appreciate your taking the time to join us for these incredible talks that we'll be having over the next few days. So in starting, I'm really pleased to be able to introduce our speaker today. He's somebody that my daughter is 20. She has trisomy 18. She's 20 years old. So I've known him, Dr. Carey, since we met him at when my daughter was just about 5 months. He gave us the hope that she was here for the long haul. And it really was just an amazing time going to see him and having the time to finally hear some positive about her, and she's just doing great. And so, had Dr. Carey in our lives that long, we're very grateful for him. Throughout his career, Dr. Carey's been interested in birth defect syndromes and the care of children with these conditions. He graduated from Villanova University in 1968 with an AB and obtained his MD from Georgetown University of Medicine in 1972. He trained in pediatrics and genetics, dysmorphology, as a resident and fellow at the University of California, San Francisco in 1972 to 79. Dr. Carey obtained an MPH from the University of California at Berkeley in 1976. And I moved too far down, I apologize. Really went there, hold on. All right, that's embarrassing. Anyway, but in between his residency and fellowship years, Dr. Carey joined the faculty at University of Utah Health Services Center in 1979. He became chief of the Division of Medical Genetics in 1985 and remained in that leadership position until 1999 when he stepped down to assume the role as editor-in-chief of the American Journal of Medical Genetics. He held that editorial position from 2001 to 2016 and is now editor-in-chief emeritus and associate editor of the journal. Dr. Carey established the Medical Genetics Fellowship Program at the University of Utah in 1985 and was the program director until he stepped down in 2014, but continues as a mentor and teacher in the program. Dr. Carey's research focus has been in the congenital malformations, neurofibromatosis, and syndrome delineation. He has authored and co-authored over 300 papers, chapters, invited articles, and editorials for scientific journals. He also co-authored the textbook Medical Genetics by George Carey Baumschad, now in 5th edition. The book is widely used in text in schools of medicine throughout North America, South America, and Europe. Dr. Carey has served as medical advisor and founding professional for the support organization for Trisomy 18-13 and related disorders since 1980. The medical and ethical aspects of the care of infant and children with these conditions and related disorders is currently a major academic interest. So with that, I just want to say from my heart how very appreciative I am for Dr. Carey and all he's doing for our children with trisomy. Appreciate having you in your life. Over to you, Dr. Carey.
Thank you, Terry. I should have abbreviated that for you. Greetings from Salt Lake City and welcome to the SOFT Virtual Conference 2020. I appreciate the opportunity to share my reflections on what has become my favorite topic. My talk will be the first of 3 in a series of the care of infants and children with trisomy 13 and 18. The others will be by Dr. Menon, Cardiology, and Green, ENT on Wednesday, and Drs. Weaver and Burge from the Nebraska Children's Hospital on Thursday, all at the same time. 2 Central Time. I want to graciously acknowledge Kelly Hernandez and Terry Kreutzer for orchestrating these virtual conferences. And also I want to acknowledge the leadership of Barb Van Haraway, president of SOFT. My talk will be an overview, a broad stroke sampling of themes, but ideally rich in scholarship and a focus on the kids and their families. I'll identify the issues in care. Most of my content is present in an article that I'll cite in a few slides, and also in the latest chapter in the book, Management of Genetic Syndromes by Cassidy and Allenson, that will be out in print in October of this year. My experience with the 2 syndromes is somewhat unique as a medical geneticist. I worked with Chris Holliday, founder of SOFT and the mother of Carrie, who was my patient in the late 1970s, and Carrie had trisomy 18. I helped Chris form SOFT, which clearly had an influence on my own views. That experience has deeply enriched my view of the syndromes. I've attended all of the SOFT conferences since 1987 and have likely seen more older infants and children than most of my colleagues in the field. Let's make sure I can share this properly. And maybe Terry could come back on and let me know for sure that that can be visualized.
We can see it.
Good, thank you. So this is Perspectives on the Care and Management of Children with Trisomy 13 and 18. As mentioned, this is sponsored through the SOFT virtual conference. I appreciate the privilege of being able to share this. Entwined in my review of the literature on the topic, I would like to emphasize that it is the children with these 2 syndromes and their parents that have had the most impact on my view as I've evolved over these 40 years in my own journey about the syndromes. So I will identify, the purpose is to identify the important themes in the care and management and to provide you with a concise summary of the phenotypes, some on the survival data and developmental outcome of children with the 2 syndromes. After the talk, I hope you'll be able to list the important and distinctive features of the 2 syndromes, summarize what is known about outcome, and identify these key issues that we'll talk about surrounding care. So this is the outline of my talk. I'm going to present a background which will review some premises that I think exist in the view, the unique view toward these 2 conditions. I'll mention 3 questions which are discussed in the paper that I'll cite in a few moments. I'll spend a little bit of time, but it could be its own talk, on the natural history of trisomy 13 and 18. I'll discuss 18 first because it's more common, and then I'll close just with some reflections on shared decision making. So let me just identify some points that I'm not going to talk about in detail, but I think are important historically. And that is, some of the controversy surrounding the care in trisomy 18 and 13 have to do with what surrounds what's existed now for about 5 decades, which is the notion of, that often comes up in care, of the selected non-treatment of handicapped infants. That's actually the title from the paper. So I would love to have the time to talk about this in detail. It also becomes its own talk, but there are a number of landmarks, including an important case of a child with Down syndrome who didn't have intervention in the early 70s, and the stories that surrounded that in the news. The seminal article by Duff and Campbell in 1973 in the New England Journal of Medicine, and Lorber's work in the care of children with spina bifida in 1975 brought out these issues that perhaps in the care of infants with at risk for handicaps and with significant medical problems, the option of no treatment or withdrawal of support should be on the table. In Down syndrome in the 1970s, as a pediatric resident, it was common for us to not offer intervention, including surgery for children with intestinal obstruction. I had seen that occur during my residency. With the baby dose story, which again I won't talk about in detail, in '82 and its aftermath in '85, that had a pivotal role in changing some of the views that surround Down syndrome, and now we tend not to think of Down syndrome in the same paragraph as 18 and 13. There are some other key references in this discourse. The paper by Bose in Lancet in 1992, which argued that and I think began the conventional wisdom of non-intervention in the care of infants, with, in particular with trisomy 18. And lastly, I'll point out an important book that appeared this past Christmas time from the New York Times about persons with disabilities and their view, called About Us. I would recommend that book if you're not particularly familiar with it. So here are the premises I'm going to propose to you. And I'm going to lay this right on the table from the beginning, which makes the care and management unique in 18 and 13. And that is that the conventional wisdom, at least from my perception around the United States, Canada, and Europe, is a non-interventional approach. This actually really becomes the culture, but there is now, fortunately, very compassionate comfort care that occurs, and that tends to be the avenue that's often pursued. There's been an emerging dialogue, which I will date from the mid-2000s, which doesn't necessarily challenge that view, but at least presents another view in terms of potential care. One of my neonatology colleagues once said that this discourse around the care really was somewhat of a palpable tension. More on that as we go along. The dialogue, I think, really started to come to a point in 2008 in a paper by McGraw and Perlman, neonatologists in New York, where in pediatrics, they did a survey study which indicated that more than half of New York neonatologists indicated that they would not resuscitate an infant with trisomy 18 in the delivery room who also had a VSD and was prenatally diagnosed. They didn't say that they would speak to the family about it. They didn't give them that option. They just said that they wouldn't resuscitate. The other 40-some% said that they would, or that they would talk to the family, or had some other options. So I think that this paper kind of began that dialogue, and I continued it in a paper that I authored in December of 2012 in Current Opinion of Pediatrics. And much of what I'm going to talk about in the next 30 minutes or so is summarized in this paper, and also in the chapter that I alluded to called Perspectives on Care and Management. And in this paper, I posed 3 questions, which is what I'm going to pose for you actually in a moment. But before we do that, let me cite some other papers in this dialogue that are important. The same year as my paper in Current Opinion, there was a paper authored by Annie Janvier and colleagues in Pediatrics, which talked about the experience of almost 400 families ascertained on social networks and their view of often having lost, but also caring for a child with trisomy 18 and 13. And I refer this paper to you. Please read it. It's probably one of the few really detailed discussions where one gets a view, at least, of the parent's perception of quality of life. I will indicate that I think more work needs to be done on that topic. Another paper appeared in Current Opinion of Pediatrics about a year and a half after mine, which I think is also a very important paper by Lorenz and Hardart. And they really did a fantastic job, and I'll refer back to this in a few moments. Fantastic job, I think, really in identifying the issues that kind of had emerged in the last few years, especially around support groups and how that influences, and even the disability rights movement. So again, for key papers, I also recommend that particular work. And lastly, in this line of, or next to lastly, in this line of important papers that I hope is laying the groundwork for the discourse, Hao et al. In the JAMA Pediatrics in 2017 really advocate for a shared decision-making approach, as others have done as well, in care, and I think is an excellent paper providing some of the balance of this part of the topic. And lastly, in my series of papers, just to lay the groundwork, my colleague Marty McCaffrey at University of North Carolina, a neonatologist there, wrote a really, I think, captivating paper in 2016, the American Journal of Medical Genetics, where, among other issues, he suggested at the present time, right now, in these 2010s, we're in a similar place where we were with Down syndrome in the 60s and 70s that I mentioned to and alluded to earlier. So with that in mind, let me pose these three questions. The three questions, as I put in my paper, and I'm going to answer some of them in the next 20 minutes or so. That is, first, are trisomy 18 and 13 uniformly lethal? As you'll see, they're not. It's important to identify our variables and outcome, but I'm not going to be able to discuss those in detail today. Second question, what is the neurodevelopmental outcome of older children with trisomy 13 and 18? Again, I'll oversimplify it, but of course, I do want to mention this. And of course, it is tied in somewhat with the recurring issue that comes up that is usually discussed, the issue of quality of life. And thirdly, throughout this entire presentation, interlaced in these questions, I will talk about the basis of what I think is the controversy. So let me spend a few moments, this will be very concise, on natural history. There are many review papers on this topic, and I don't intend to do an entire review of phenotype because that is present in many review papers. But I think trisomy 13 and 18 are unique among the more common congenital malformation disability syndromes that we take care of as pediatricians, neonatologists, geneticists, nurse practitioners, and the like, because of these three aspects. A very high frequency of medically serious congenital malformations, especially heart defects, occurring at a frequency of 90% in trisomy 18. The increased neonatal and infant mortality that is associated with both these syndromes, and I will summarize the survival figures from the population studies that are in the literature, not the hospital-based studies, of which there are a number, which provide a bias, but the epidemiologic population studies. And thirdly, the other unique aspect is the neurodevelopmental outcome, which I alluded to earlier. Cited at the bottom right is that same paper I mentioned earlier, plus another paper I wrote in 2012 with a pediatric resident, Anna Chireta, which is a review on trisomy 18. So trisomy 18, the most common, second most common autosomal trisomy syndrome after Down syndrome. Prevalence is about 1 in 6,000, and it's a recognizable pattern, and I already mentioned the key features a moment ago. The phenotype consists of being small for gestational age, typical but not very distinctive facial features, characteristic posturing of the hands. Again, I'm not going to discuss those in detail. The short sternum and the occurrence of the medically significant congenital malformations. Here's a photograph taken from Lancet of Sarah, the first patient of John Edwards. He published his paper as a 2-page case report in Lancet, emphasizing the importance of case reports in Lancet in 1960. Interestingly, the paper on trisomy 18 was back-to-back with the paper with trisomy 13 by Patel. Notice many of the features in Sarah, trisomy 18. She was a few weeks old in this picture, and then Dr. Edwards and his colleagues went on to show that there was an extra E group chromosome characterizing the trisomy 18 syndrome. There's Dr. Edwards on our right with his wife on our left, and that's Kyle, one of my longstanding patients I've met with trisomy 18. They're at a picnic in St. Louis at a SOFT meeting. Dr. Edwards passed away a few years ago of continued correspondence with his wife, and I had the privilege to get to know him over a few decades. So 3 kids I know with trisomy 18 all now have passed away. In the upper right hand is Rachel, and that's Carrie there with the yellow dress, daughter of Chris, founder of SOFT. Get to know both of those parents and children, and that's what led in 79 and 80 to the creation of SOFT. The young lady down on the lower left, a child from Chicago, that got to know her family at a SOFT meeting, and her picture is actually depicted in the textbook by Jordi Baumshed, just again showing the features. Again, I'm not going to spend time on this in detail today. There are other sources. I think it's just important to mention some of the important features and frequency because it helps lay the groundwork for the medically significant malformations. But I think what's as equally important, and perhaps we could say more statistically important, are the other medical conditions in the functional category, sometimes anatomically defined, the respiratory difficulties, both central apnea, obstructive apnea, and then the lower airway kinds of issues. I think in the last decades, it's my impression that we have not done enough work in defining the airway issues in trisomy 18 and also in trisomy 13. We've kind of oversimplified it often as to being simply central apnea, but it is more complicated, and that will be Dr. Green's topic on Wednesday. Then you can see the significant feeding difficulties often associated with aspiration, frequently requiring the placement of a GE tube, and leading to all of them together, leading to very ongoing chronic disease issues. So at least in our institution, our complex care team is frequently being the sort of home with the primary care doctors for these kids. So again, the kind of capturing the most significant natural history issue of 13 and 18 trisomy, and that is this issue of increased neonatal and infant mortality. The principal cause of this increased mortality in the first few days, weeks, months, and year of life are a complex. Central apnea, hypoventilation, the aspiration, often related to reflux, upper airway obstruction, and sometimes a cardiac defect playing an underlying role, or in the case of hypoplastic left heart, playing a more major role. And I think it's important to actually to discuss some of these figures because it's such an important aspect of discourse that will occur both in the prenatal setting, certainly at the time of birth, and also in the newborn intensive care unit. So just to summarize those, I'm not going to go through the primary data. I refer you to the papers. The studies I'm going to briefly overview here, other than the one by Weber on the top, the other studies from 85 and 94, there are 4 of them, 6 of them from 01 to 15 are all population epidemiologic studies in a defined period with a defined geographical region. The only way I think we can reasonably come up with survival curves and risk estimates of mortality or survival. The group from the papers from 85 to 94 from the US, including our Utah study, 2 studies from Europe, and a study from Australia, and then studies with more numbers in 01 to 15, where the numbers went up to as many as 300 cases in a Texas study and over 100 cases in the CDC study and in the UK studies, all coming up with a somewhat similar set of risk figures. But notice I bolded at the bottom there 2 recent studies published in JAMA, the American Journal of Medical Genetics, in 2016, both papers published a short period of time that show a much different outcome number with much larger numbers, and I'll go through those in a little bit more detail in a moment. But just to give you a composite of the figures, the 10 studies from 85 to 16 on average, or together, the range show 1 week survival of 25 to 45%, so that over 50% of children have died by 7 days of age. The 1 year survival ranged in those 10 studies from 2 to 8%, with the later studies shading more toward the 8% number. The median survival was usually in single-digit days, 4 to 14 days, the CDC study being the 14 days, again, having about 100 cases. I'm not going to go through the survival and mortality studies of trisomy 13. First, there are only a few of them. They only number 4, and they show remarkably similar figures. But in 2016, 2 papers appeared, which I think add to this dialogue that I'm referring to you and make the story more complex. First of these was by a paper by Bob Meyer from University of North Carolina. It was a multi-state investigation over a 9-year period, which actually included 693 cases of trisomy 13. Most previous series were less than 100. And over 1,000 cases of trisomy 18, most previous series were less than 300. The 1 year survival of trisomy 13 was 11.5%, and the 1 year survival of trisomy 18 was 13.4%, about a doubling of the overall average risk reported before. What was equally interesting was that the 5-year survival was about 90% of that 1 year survival. That is, of the children who survived to 1 year, much more than the majority, close to 90%, survived to 5 years. So this survival in the first few months, but especially to 1 year, is quite an important landmark and probably shows you a selection of kids. But it's also showing a mix of children who might have had more intervention in the 2000s compared to what had existed before, and that intervention including cardiac surgery. Another paper appeared from Ontario by Nelson and colleagues, also in 2016, published in JAMA, which showed almost identical figures and identical four-digit figures for trisomy 18. So when I asked the question here, posed originally, are 18 and 13 uniformly lethal? The answer is no, because even in the earlier studies, the mortality was ranging about 5%, survival ranging about 5%, and now it's about 12%. So let me discuss one other paper in this context, and that paper is by Tomoki Kosho and his colleagues from Nagano Children's, appearing in 2006, and I think helped launch this dialogue. That was a paper of 24 patients with trisomy 18 at Nagano Children's who were offered complete care if they chose it, and in those that Dr. Kosho and his colleagues offered the care to, the 24 patients did accept full care, full intervention. They were not able to carry out cardiac surgery there at Nagano Children's at that time for infants, except for ligation of the ductus. So cardiac surgery was not a part of these figures, but the median survival in that study was much higher than 7, 8, 9, 10 days. It was 152 days, and 6 of the 24 or 25% did survive the first year of life. And Dr. Kosho, I think then that work brings up the issue that previously, and I myself would frequently say, even in the late 2000s, that I didn't know that there was evidence that medical intervention made a difference. But I think the Kosho study and the work after that, especially the studies about cardiac surgery, which I'm only going to have a chance to mention and not touch on, the Kosho study, and then the improving survival figures in the US and the UK that I'm referring to, and the cardiac surgery studies, some of them still represent case series, but some of them have much larger numbers, do show better survival after cardiac surgery than expected, thus further increasing this issue that what I would propose is that medical intervention does make a difference. So just switching gears to trisomy 13 for a moment, I'm only going to mention this briefly because I do want to leave at least 15 minutes for discussion, and my goal is not to discuss the phenotype in detail. Trisomy 13, third most common autosomal trisomy, prevalence average is about 1 in 12 to 13,000 liveborns, and again, a recognizable pattern, as you know. Trisomy 13 is often more recognizable than trisomy 18 because of the high frequency of orofacial clefts, microphthalmia, and postaxial polydactyly. Here is the first patient with trisomy 13 reported in the same issue of Lancet I mentioned earlier by Klaus Patel. The last author on that paper was Dr. David Smith, the father of dysmorphology. This child, as you can see, although we can't see the eyes open, did have severe microphthalmia, would be called anophthalmia, bilateral cleft lip, and polydactyly. And again, just like in Oxford, the same time period, Patel's group, Patel was working on cytogenetics, one of the fathers of the field. They determined that this infant had an extra D group chromosome. Later on, of course, to be trisomy 13. Here's a friend of mine of many years, Erin from Chicago. This picture is also in Jordy's textbook of medical genetics. Here's Erin when he's about 6 or 7. He's able to sit up, stand, use a walker, use a gait trainer, quite social, able to feed himself, not able to speak. Overall functioning is probably less than 12 months of age, but a number of his skills would be in the 2nd year level, just to begin to give you a flavor for that issue about outcome. And again, just a brief list of the more important congenital medically significant malformations, trisomy 13, and 80% having heart defect. So that's the almost the end of my discussion of natural history. I'm going to show a few more slides, but just to in between begin what I will show you as kind of a photo album of some of the children I've met at SOFT and some of my own patients. This is a young lady from Sweden, pictured when she was in her early 20s. She passed away at 30 of pneumonia. The young lady to her right is now an orthopedic surgeon in Sweden, and this family for many years came to the SOFT meetings, and I got to know them. So again, still discussing natural history, just a few more points. This is my friend Erin here from Utah, who's now 8 years of age. And there's Christy, Terry's daughter. She mentioned her early in my introduction. So children with trisomy 18, they're in the medical literature, there are 15 reports of children over the age of 10. 5 have had a skin biopsy to demonstrate that they didn't have mosaicism in this case. Most of them were girls. One child could walk unassisted, but Dr. Kosho's further work in Japan has shown other children who can walk with trisomy 18 walk unassisted, and I've met other children at SOFT. But here's what's of note. There are actually more than 40 individuals in SOFT that we know over the age of 10, and more than 20 who are actually over the age of 20. There's the SOFT webpage, trisomy.org, including the SOFT UK webpage. One of my young ladies that I followed here for years in Utah, who lived till she was 35 years of age. Physicians in the audience can know that she had her blue lips because she did have Eisenmingers from an unrepaired VSD. She passed away of pneumonia and secondary renal failure. Here's Stacy, the child of the Van Haraways. That's Barb on our right, who's president of SOFT, who I mentioned earlier. And Stacy actually also reached her 35th birthday, but did pass away exactly 2 years ago from medical issues. And there's my friend with Utah, with Joey on her left, who's one of the boys I know, who's 18 in this picture with trisomy 18. And here's another picture of Aaron there. And this is Luna, patient I follow here in Utah. She's 4.5 years of age. Her overall skill level would be probably at about the 12-month level. She can stand, walk with a gait trainer, take a few steps, sit up well, communicates readily, but is not saying any definite words, but is highly social. We know that she has full trisomy 18, as she's had actually 3 samples from 2 different in blood and 1 from buccal swab, showing she has full 18. In trisomy 13, there are 15 reports of children over the age of 3, lower age usually characterized. None in the literature were able to walk, but currently now, Amy, one of my fellows I'm working with, is doing a study of adults with the Living with Trisomy 13 Facebook group, and we know of a number of adults now with trisomy 13 who are able to walk. Here is Tucker, a boy that I followed at trisomy soft meetings for a number of years. And here is Aaron, the boy I showed in the black and white picture a little while ago, who's now you can see older and quite social. So in the few moments now, I'd like to just summarize the developmental outcome of what we know about older children with trisomy 13 and 18. And then I'd like to just say a few words about shared decision-making and probably move a little bit quicker through my last slides than I wanted, because I do want to leave some time for questions. There is Megan with full trisomy 18. Her parents, Frank and Ann, and Ann's a nurse, created the SOFT registry, which I'll mention in a few moments from now. And Megan, I first met them at the first SOFT meeting in 1987 in Salt Lake City. So Bonnie Beatty, my colleague, the creator of our own genetic counseling program here in 1994, published a paper in collaboration with SOFT where she collected developmental milestones and developmental quotients in trisomy 18. Other than some work by Debbie Bruns in Southern Illinois, there really isn't very much on milestones or even on objective measures of development in trisomy 13 and 18. There is one work on language scores by Barb Braddock, but otherwise not very much around. But you can see the milestones: smiling at 4 months, in 18, 5 months, and 13. And in Bonnie's paper, she did all the milestones, but I won't discuss them here in detail, just refer you to them. But here she also collected developmental records, and I'm just going to highlight the 3 to 5 year age group of kids with trisomy 18, kids with trisomy 13. Their chronological age was around 46 months, 44 months. And their developmental age from the DQs taken from different instruments in different parts of the country was around 7 to 8 months. But it's important to mention, as I did earlier in talking about Luna and one other child, that many of the children had skills that were in the second and beyond life, a second year of life. Even though their overall skill would have been averaging 8 to 10 months. 2 families at a SOFT picnic that met a number of years ago. So let me spend the last few moments just kind of identifying points that might be under the category of bioethics discussion, at least touching on issues about cardiac surgery, which deserves its own talk in and of itself, but hopefully to pique your interest and pique some of your knowledge, and discuss this in more detail. To discuss that in more detail for yourself. So I point out 3 important papers for you. And these important papers really, I think, in the discussion of these papers, really, I think, characterize all the issues that I'm going to summarize on the next 2 slides, just for the purposes of identifying the themes. Again, because I'm covering this as an overview and broad stroke, some of this will be covered by Megan on Thursday, some of it will be covered by Dr. Menon on Wednesday. You'll see their talks if you're unable to attend them, because they will be videotaped and saved. But again, the McGraw-Hill-Perlman paper in 2008, one of the things I want to mention about that paper is that McGraw did make the case that she and Perlman, her co-author, felt that the pendulum of decision-making was swinging in the favor and overweighing parents' decisions when discussions would occur about intervention or non-intervention. She also very astutely and eloquently lists some of the other issues, which I'm going to show you in a moment. A really important paper by Kugler and 2 ethicists, Ben Wilfon and Lainey Ross, also go on to identify these issues about allocation of resources, quality of life, who makes a decision, especially in areas of uncertainty. So if you want to read at least the identification of these issues, I refer you to those papers. That was in the Hastings Center. And lastly, as mentioned earlier, the paper by Lorenz and Hardart does the same. So McGraw and Perlman, as I mentioned, really go in detail discussing the theme of best interest in the child, parental autonomy, and they're concerned about the pendulum swinging in that direction. And they do discuss about making the decision. In the paper by Wilfon and the group, they make the case in areas of ambiguity, erring on the side of the parents having a major role in decision making was their recommendation. But you can't get away from a discussion of this without also identifying allocation of resources. All 3 of the papers discuss that, and even issues of quality of life. And of course, pain and suffering brought up so commonly, importantly in these discussions, in the NICUs and the PICUs. Lorenz and Hardart, I think, modernized some of the issues that have been identifying in the other 2 papers in their paper in 2014, where they actually discuss improvements of treatment, mention the cardiac surgery issues, talk about disability advocacy support groups, and the roles of social network that have entered into care issues. And I think have a good discussion on the ethical justifications for treatment and non-treatment, carrying on that discussion I told you about in the 2nd or 3rd slide that had begun in the late 1960s and 70s, carrying it on and really modernizing it. So I'm not going to have time to even discuss these cardiac surgery slides in detail or review it, because I really think it's important to leave time on questions, but I'm identifying for you the key papers on this slide and the next slide for you to be able to read them as well. I did mention the chapter that I authored, which will be coming out in Cassidy's Management of Genetic Syndromes in October of this year in that book. And I do actually discuss these papers in detail, and I'm sure that Dr. Menon will discuss this on Wednesday, and if you can't hear his talk, you will be able to access those talks. But the bottom line of this are in these recent surgery studies going back into the mid-2000s, on average, about 85% of children who did undergo heart surgery for different indications and different types, on average, about 85% were discharged from the hospital. And that was characterized in one of the important recent papers in Annals of Thoracic Surgery by Peterson and colleagues. But of course, this issue of cardiac surgery is controversial and is embedded in this discourse that I'm referring to. The SOLF registry has now over 150 children with trisomy 18, full, complete 18, not mosaic, not partial, who have had cardiac surgery, most of these having occurred in the last 5 to 8 years. And I didn't update that figure, but it's over 150 now. Trisomy 13, over 135, over 35. And this is Ann Barnes' registry that I alluded to earlier. Here's one of my own patients here in Utah, Ashton, pictured when she was a little over a year, and then again a few years after cardiac surgery in the picture on our right, and after G-tube and other care. And there's my friend Sam, who's just had his first birthday 2 months ago. And Sam's here in Utah, but he did travel back to University of Nebraska to have his cardiac surgery in the summer of 2019. And here, for those that knew Sam at Nebraska, some relatively recent pictures that his mom sent to me. Sam is actually doing well now. You can see he also has tracheostomy. So these issues about shared decision-making and goals of care are characterized in a number of papers that have been published in the last few years. I already mentioned the Lorenz and Hardart, and they're quite eloquent in their discussion. This paper by Sasha Andrews, a OBGYN, come from a Denver conference, which was put together to talk about some of the decision-making issues in trisomy 18 and 13, characterizes a lot of this and actually does recommend, as does the Haug paper I mentioned earlier, shared decision-making. So to summarize, and I admit that I've covered a lot and did give you broad stroke overviews, but hopefully gave you the resources and references for you to review these issues in more detail in your own care and your own help. But just to summarize, earlier studies showed an overall survival in trisomy 18 and 13 of about 5%, but 2 recent studies with much larger numbers show survival at around 12%. Survival to 5 years ranges from 4 to 12%, probably centers around 10%. Children with trisomy 18 and 13 do progress in their developmental milestones, albeit slowly, and their overall skills can be at less than the 1-year level, but they still progress in their milestones and have some skills even in the second and sometimes beyond that level. And of course, I would advocate that a shared decision-making model is the approach here. That's, of course, always easier said than done, but it should be the approach that we would have. So I do have some references that are posted. I'm not going to keep them up now. Have a dozen references or so posted. I've mentioned some of them. Hopefully they're easy to find nowadays. And if you can't find them and you want one, please email me. But I'm going to stop at this point with about 12 or 13 minutes to go, and open this for questions. So I'm going to stop sharing there, come back up on the screen, and open this for questions. I think Terry or Kelly, you have to come on now, I think, right? And let me know about letting someone on whose hands might be raised.
Right now, we don't see anybody's hands raised. So if anybody does have questions, you can either put them in the chat or you can raise your hand and we will give you the ability to ask Dr. Carey your question.
So while we're waiting for that, and please interrupt me, Kelly. While we're waiting for that, I'll just mention a little bit that I skimmed over about the cardiac surgery studies. There have now been, there were in the 2000s, 5 papers that were case series from Japan that showed some of those leaving the hospital figures I mentioned. And then in this decade, there have been 4 studies just in the last 4 years, including the one that we participated in, Dr. Menon and I, from University of Utah by Dr. Dominguez, that all have the experience of surgeries ranging from 50 to a few hundred cases. I am currently doing a survey study of the families registered in the SOFT registry that I mentioned to earlier with Dr. Menon and Ann Barnes, where we're going to query the families about outcome, because we only know they had the surgery. We don't know what happened after the surgery, other than if they left the hospital or not. So it must be Kelly and Terry that I was as clear as a bell, right?
Yes, and I have a question. And one moment, and I'm going to give them permission to speak. Hello?
Hello. Hi. Thank you for giving this talk, because I think this is a topic that in the palliative care world that we think a lot about. And it's awesome to see that people are doing work to help support these families who have these really great kids. My question has to do with just how, in kind of like that shared decision-making model that you were talking about, what's your approach to families who kind of have these big questions of, I have a child who has a trisomy diagnosis, and we are in an institution that isn't necessarily doing procedures like heart procedures or feeding tubes and certain things for kids with trisomies, but at the same time, we don't have a lot of resources or have other reasons where traveling is also going to be really difficult. What's kind of your approach to advising that family or talking with that family about kind of weighing these very disparate, often life decisions that they have?
Right, that's really important and really complicated questions, because, and keep in mind that while I have many colleagues who are neonatologists, and I once aspired to be a neonatologist, I'm not one. So, you know, I'm involved in care conferences still at this point in my career on a regular basis. But when we're in that position that you discussed, if you in the neonatology world are helping to lead that, and a family is moving toward intervention, especially if a child is older, days, weeks, months. I think options about transferring care, which I won't, have to admit how complicated that is, seem to be where one can go, both for placement of G tubes, if that is the case, or even, as is the case that tends to occur a lot in the cardiac surgery world, transfer to another institution. I always am mixed about that myself, because I feel as if, we always naturally want to keep our patients in our own institution. But I don't know that we have any other options if that's where the family wants to go, and they're very well grounded in that decision. So one thing on this line, in the SOFT registry that Ann Barnes created, and in the question of where else one may go, there is actually a resource for finding in a neighboring institution or neighboring state where someone might accept that transfer, because that could be its own logistic challenge.
Thank you.
Well, thank you for the question. I think there was a
Okay.
chat I saw there, Kelly.
Yes, and I'm getting to that. We have one that says, Tara Garst says, I've seen a few children that have higher abilities, such as recognition of words, simple math problems, etc. However, their physical abilities pose considerable creativity to assess this knowledge. Have you seen this in your practice?
Thank you. That's again a great question. I think that what I've seen is, if I just pick little Luna that I showed her pictures of, but other children I've seen with augmentative communication. But I think that more than likely these older children with trisomy 18 and 13 probably have the ability to communicate and understand more than we can know. And there are probably an awful lot of parents who know more about that than I do, but I've witnessed as parents have shown me those kinds of skill sets. So I think in the world of augmentative communication, in the world of advancing that kind of computer knowledge, I look forward to an older kids that maybe we will have more advances in communication and skill levels than what we now sort of oversimplify.
Okay, then we also have from Laura Elmer. She says, Dr. Carey, the concept of shared decision-making seems to be facility dependent. In my experience as a pediatrician and mother of a child with trisomy 18, it is clear that bias is prevalent. Do you have facilities that you recommend for cardiac surgery in the United States for children with trisomy 18?
Great question. And like I said, I kind of offhandedly said easier said than done about shared decision making. I'm not sure anyone would deny it, just like no one would nowadays deny patient-centered care. But again, those are to strive for and not always actually easy to carry out. I think that there, and I'll say this for the record, and all of my neonatology colleagues here at University of Utah, who I have tremendous respect for, all of them, know how I feel about this. I do think that there is somewhat of a bias in care about trisomy 18 and 13. And that bias of care has a shade of difference that I can't necessarily quantify between how we discuss hypoplastic left heart care and how we discuss the care of the 22 to 24 week premature baby. Again, it's a matter of quality, not necessarily something I can quantify. I do think that there's an aura around trisomy 18 and 13, and I guess I don't by no means want to sound like I have some enlightenment. Any enlightenment that I have or any epiphany I have has come from what I've learned from the parents and kids. But I do think this worldview does sometimes play a role, and that there are people who openly tell me, some of my colleagues, that they do have the bias that they think it's better to not intervene, and that would save pain and suffering, to again use that word in broader context, for both the parents and for the child. So I think that I don't know the answer to that question, and that is for the parents. So what I would advocate is the complexity of these issues and to recognize that bias if it's present, and for the parents to be in a major driver's seat in that area. To answer your question, at the risk of sounding like I would be advertising for the doctor's question about any institution, you may know that the cardiac surgeon at University of Nebraska Children's Hospital, is willing to review the records, and Jim Hamill is his name, and accept a child as long as their insurance will pay for the transfer and also for the cardiac surgery if, as he looks at the records, he can deem them eligible. I do know that there are other institutions in the United States, including Stanford and including Boston Children's and Children's of Philadelphia, that have operate on kids with trisomy 18 and 13 in the past. But as you already alluded to in your question, it seems to be not only institution dependent, but sometimes even attending dependent, or I don't mean to say that whimsically at all. If this comes up, especially in the previous question about where to transfer, there are ways through SOFT to help with that. We can provide the institutions that actually have done cardiac and other surgery, because Ann Barnes's registry is not just for cardiac surgery, it's for another 30 surgeries. So I like to think that SOFT is a touchstone for being able to at least find out the names of the institutions that have been willing in the past to be open to the decision. I know we're getting close to the hour, and I think you've told me before that Zoom won't kick us off, Terry, so we can continue beyond the hour unless they kick us off, but I recognize we're now at the hour, so anyone who scheduled something for the next hour, please don't feel bad about leaving the meeting, but I'm happy to, I know Stu, I can see there are more chats. I'm happy to keep continuing.
Okay, we have another question from Shauna DeMars. She says, thank you so much for this, Dr. Carey. It seems like medical studies take such a long time to translate into practice. What more is being done, and what can we do to help inform our colleagues on these updates with trisomy 18 and 13?
Again, good question, and I think that's something that maybe have been too slow in the game since that is SOFT, including my role. We want to take a larger role in that all of the time. At this point in my career, I'm hoping to actually make some of that information more available. The problem with a book like Management of Genetic Syndromes is that nowadays for our medical students and residents, you know, if it ain't on the internet, it doesn't exist. So I acknowledge that being the case, but right now with my fellow Amy, we're co-authoring a review for the Rare Disease Journal on trisomy 13, which is an open access paper. And I'm trying to engineer the publication of additional work in this line. So hopefully the momentum for continuing to publish continues, because I am a strong advocate for believing that we do have to have peer-reviewed work in the literature with data to demonstrate what is the basis of these decisions. That I prefer going beyond case series and prefer studies like the recent cardiac studies. On the same line, one last point. I have been in communication with the American College of Medical Genetics and Genomics, who actually do systematic reviews of topics. And I am proposing, now that we have more than 10 studies, including case series, doing a systematic review of cardiac surgery in trisomy 18 and 13. I'm sure that's still a year away from completion, but do want to continue that work.
In the line of that, we have a question from Audrey Berman. She said, have you seen a shift in surgeons offering cardiac surgery to kids with trisomy 13 or 18? In her experience in New York City, most surgeons do not offer surgery.
That's been my impression from what I hear secondhand about New York myself as well. And there are hospitals in the country that have made specific stands that they don't operate on infants with trisomy 18 and 13. That we're having, you know, we had in the previous discussion, we know that the Children's of Nebraska has actually said that they will accept cases. There's a nurse coordinator there. I know that because they mentioned it to me in particular, I didn't say it earlier, that at Cardinal Glennon in St. Louis, connected with St. Louis University, also accepts patients. So the answer to your question, yes, I've seen more. I had a conversation We had a conference call a few weeks ago, Barbara and Harlan and I, with a surgeon and coordinator at Boston Children's Hospital. They were part of the Peterson study as well about where they're moving there. So I think the attitudes are changing. I think some of that mold is, if you will, is becoming softer, but we still have, there still exists this world view that for reasons that could be debated, this particular institution is not going to offer surgery or cardiac surgery. Notice our last, three of our last 4 questions all are around that theme.
And then we have Dr. Showalter, who I'm going to bring on to ask his question.
Please bring on Dr. Showalter.
Here we go.
Hi, John. Can you hear me?
I can hear you very clearly, Scott.
It's Scott Showalter, and this may be a question that could be more appropriate for the 3rd talk this week, I think, for professionals. But I was wondering your experience or impressions now that we have more non-invasive prenatal testing, specifically cell-free DNA testing on pregnant moms. If your experience is that that has had any influence on parents' decisions to terminate pregnancies or not, what's your impression of the influence of those newer tests?
So Scott, thank you for the question. And Dr. Showalter, as a pediatrician, now quasi-retired in Denver and a longtime associate of mine, former classmate, in fact. So I don't have any numbers, Scott, and perhaps maybe it's been studied and I haven't seen it yet in the prenatal world. I think that by having the cell-free DNA and having the a highly sensitive test with 99% sensitivity, but lower predictive value, predictive value, depending on the labs, 70, 80, 90%, but high sensitivity. My impression here is that most families, when they have a positive test, are still going on to other diagnostic measures such as amnio or ultrasound confirmation before they would terminate the pregnancy. But I know in some parts of the country, some will make that choice just based on the cell-free DNA, even though the positive predictive value is not as high as the sensitivity of the test. I can't say that I've seen that impact here or that I can comment on it nationally, because I think our OB colleagues have been fairly excellent about suggesting that this is a screening test. It's not a diagnostic test, and we need to do other tests to go forward. Certainly there are figures around, and the latest figures I've seen are more from Europe than America, not so much about knowing about cell-free DNA, Scott, but knowing about the frequency of pregnancy termination at certain points in pregnancy when 18 and 13 are picked up. We have those figures, but I can't weigh in the impact of cell-free DNA per se.
Thanks.
That is all the questions that I can see, and I don't see anyone else's hands up. So if anybody else has a question, let us know.
Well, I appreciate the fantastic questions, and for Terry and Kelly and anyone else in the soft leadership online, I think that I know that families in this position, often with their doctors, do end up finding out about other hospitals, but I think that we have to be really transparent and proactive about making sure that information is available. I think that families get it through Facebook, and thus we as an organization don't have to worry about it as much, but I want to make sure that, you know what I mean, Terry? I want to make sure that, since that came up in different ways, that families and their doctors can get to that information.
Absolutely. And all of this will be up online, and, you know, people will keep anything that comes up that families need, we'll have on the website so they can get access to.
By the way, Terry, this talk will be accessible on the website at some point.
Hopefully it'll be up tomorrow. That is my
Okay.
goal. But
Well,
give
just
me
for,
a day or two.
for future, anybody that wants the slides will be able to at least hear the talk, and we can also make my slides available if they just want the PowerPoints.
We can absolutely put your slides up on the page with the video. We're doing that with the one from earlier today as well. So if you'd like me to do that, send me the PowerPoint and I will add it on there.
Right, I'm happy to have people, since I have permission from all the pictures to, and much of the rest was from the literature. So,
Perfect.
so,
All right.
so again, Kelly and Terry, thank you so much for your orchestration of this. We had great participation. So.
Absolutely. And we absolutely are very thrilled to have been able to do this and participate in this way. It's been a pleasure to be able to bring it to everyone. We appreciate your time today, Dr. Carey. We appreciate your passion for our kids, because we know that a lot of where we are today is a direct result of the efforts that you've put in, and the families and the children and people that you've touched. And we want to thank everybody that's here today for carving out a piece of your Monday to join us. We're going to be back again later this week with our other two professional panel or our professional presentations, as well as tonight we have a welcome to the conference. We invite you to go to trisomy.org to check out the schedule. Join us any place along there you'd like to. If you're not already registered, we'll look forward to seeing you. And we'll be back again at 6 o'clock tonight for the welcome. Again, Dr. Carey, thank you. And thanks everybody for being here. Bye-bye for now.